the Gender and Women's Studies program and in the Department of Culture and Media Studies here at UNB. I just want to acknowledge that the land on which we gather today is the unceded and unsurrendered territory of the Wolastoqey people, and importantly, the treaties that were signed in 1725 were meant to govern the relationship between the peoples living on the land and not necessarily giving that land away. So I want us to think about the importance of that, especially given our topic today. Our Feminist Lunch is organized with support from the UNB STU University Women's Center, which is located in the Student Union Building, the UNB Gender and Women's Studies Program, UNB Libraries, and the UNB Women's Alumni Association. We're very thankful, and especially to the women's alumni, which are paying for coffee and cookies for our talks this year, and it's the first year, and we're very grateful for their support. Today, we're extending a very warm welcome to Dr. Martha Paynter, who we've been trying to get since she got here a couple of years ago, but haven't had any success until this year. So we're very excited to have you here with us, Martha. Dr. Paynter is an assistant professor in the Faculty of Nursing here at UNB, where her clinical teaching and research focus on the intersections of reproductive health and the criminal justice system are expanding. She's an affiliate scientist for the Nova Scotia Women's Choice Clinic and a founder and a past chair of an organization called Wellness Within, an organization for health and justice. That's the only organization in Canada that's dedicated to advancing reproductive justice for people experiencing criminalization. She's also the author of Abortion to Abolition, Reproductive Health and Justice in Canada, which was published last year by Fernwood. Congratulations, an important book on the topic. This afternoon, she's going to give us a talk entitled Abortion Access for People in Prison in Canada. So she'll talk about 30 minutes, and then we'll welcome questions during our Q&A period. Welcome, Martha. I'll hand it over to you. There's a drink thing here.
Great. Hello, everybody. This is a nice little crowd, but I will start with a land acknowledgement. We're here on the land of the Wolastoqey, and these are photos actually taken by my dad, who's right here. And because we're such a small group, and because it's so good for discussion, I was wondering if everybody could introduce themselves, just, your name and connection to feminist work. Do you want to start, Linda?
Sure. I am one of Dr. Paynter's students. I'm in nursing in third year, and she's my clinical instructor, and I just think she's amazing, and I want to learn everything I can from her.
More of this. Thanks, Linda. You passed.
Thanks.
Hi, I'm Vicki. I work at the Higher Education Commission, and I also teach part-time in the Department of English, and yeah, interested in like EDI issues and how we can put them into policy and institutions.
Nice to meet you, Vicki.
I'm Elizabeth Evinger. I teach in the English department here. I am interested, and I've done work with incarcerated women, specifically doing poetry workshops.
My name's Spencer. I'm an intern for the university's Women's Center, and I'm doing a double major in gender and women's studies and psychology, so I'm here to learn more. And of course, videotape for the Women's Center.
I'm Jacques Paynter. I'm Martha's dad. And I work for a multinational engineering company, and my primary practice areas are stakeholder and public engagement and the impact of climate change on vulnerable infrastructure.
I'm Martha Pentroms. I've been a friend of Martha since she was 2 or 3 days old. Still learning from her. Is that good enough, Martha?
Amazing, Martha. Thank you. Okay.
My name is Kathy Reed, and I've been a friend of Martha's before she was born. We taught us yoga.
Okay. Fetal politics here.
And if you haven't read Martha's book, you really should. It's so up to date and so well written. Yeah, it's great.
And pretty.
very pretty, and the illustrations are wonderful.
I'm here for pretty. But
I'm Paul Miedema. I did my PhD here at UNB, and that's a long, long time ago. And then I taught primary healthcare for Dalhousie University, and I taught a couple of courses here too in my distant past. So
what about
well, 6 years ago. No, years longer than that.
what about Canadian Federation of University Women?
Oh yes, I am a member of the Canadian Federation of University Women, and we raise scholarship money for female students. So, here in the Fredericton region. So, if anybody is interested, talk to me after.
I'm Beth Paynter. I brought her up a feminist. What do you need to know? My mother was a nurse.
I'm Anna Jose. I am the chair of the University Women's Center. I'm in my 4th year of biology, and I'm interested in learning more about reproductive health so we can provide more resources for the student body. So I'm very excited for your talk today.
Oh, I'm very pleased to meet you, Anna Jose. That's wonderful.
Hi, I'm Celeste, and I'm wearing my I Support Reproductive Rights shirt today. I'm an assistant professor in the sociology department and part of the GWS program.
Great. Well, lovely to meet all of you. Okay, when I do land acknowledgement, very in keeping with the approach that Sophie had, I'd like to talk about how we're going to apply this acknowledgement into action. And my work directly addresses pieces of the TRC in respect to the child protection system, education, and healthcare. So, number 1, reducing the number of kids in care, recognizing healthcare rights, number 18, 23, increasing the numbers of Indigenous healthcare providers, and we're trying to do that very concretely in the nursing program, and eliminating the incarceration of Indigenous people. In my work, I am very, very daily supported by my research manager, Claire. I work very collaboratively with Julia Hutt, who illustrated my book and who illustrates all of my research work, and to Dr. Wendy Norman and Dr. Sharman Rowe, who are my mentors at the Contraception and Abortion Research Team, where I am the Director of Nursing Research. So our national team is headquartered at UBC. So that's one of my important affiliations. I also wanted to give a fabulous update to my bio that I sent to Sophie, I don't know, a month ago or something. 3 weeks ago, the Nova Scotia Women's Choice Clinic, our abortion clinic in Halifax that serves through telemedicine the entire province, changed our name to the Rose Clinic, the Reproductive Options and Services Clinic. Our staff had worked unanimously and persistently for almost 3 years to convince Nova Scotia Health Authority that we needed a gender inclusive name, and they went with it, and they the name that we chose, it's a nice acronym, but it also honors Dr. Jacques Desrosiers, who has provided abortion care at our clinic for almost 40 years. In my work, I, as I said, use the work of Julia Hutt, illustrate, and this is a very purposeful decision. I'm really into beauty, and I find that when I am in prison spaces, it's so important to bring some beauty in, and I've really benefited from having Julia's resources as a different way to communicate the things that I'm talking about. So this, in particular, this is a portrait of Santina Rao, who is a survivor of police brutality in Halifax, and I talk about her in my book. So Wellness Within, which also changed our name several years ago, I'm gonna say 4, might be more, from Women's Wellness to Wellness Within. We have several different pieces of work in the community, and we started as a doula service in the prison system in Nova Scotia, and really expanded from there to do a lot of education work, things like this, a lot of research, and tons of advocacy. Because we do not have charitable status, We have no limitations on our lobbying efforts, on our political work, and we take that free rein to do the work that needs to be done. All right, so the connection between abolition and reproductive justice. I'm sure everyone is aware that the reproductive justice movement's kind of formal formation in the mid-90s by Black American feminists and women of color in the US to move beyond just the right to not have children, to include the right to have children and to parent those children in safety and security, and in particular safety from state-inflicted violence. Incarcerated people experience a whole realm of threats to reproductive justice and bodily autonomy. They are at very disproportionate risk of sexual assault while inside. Women that Wellness Within works with have charged and seen convicted guards at the Nova Institution for Women in Truro for raping them while they were incarcerated. So this is a current, next door to us practice and problem. Extreme restrictions on health services. The experience of incarceration delays and disrupts your fertility, particularly for us as queers in the prison system. Trying to build a family is hard enough, and when you face the delays and barriers to care that the prison system introduces, it's that much harder. And of course, the queer community is vastly hyper-incarcerated. And then separation from the kids you already have. So, just like reproductive justice is a theory very much focused on racism and its application in intersectionality, so too abolition must be considered through that lens of anti-racist and anti-colonial visioning. The people in prisons for women, and we use that language of prisons for women because that is what they are called. There is also a hyper-incarceration of gender-diverse people in both of the prison binary systems. Women are the fastest growing population, and yet a very tiny portion of incarcerated people, less than 10%. So what that results in is inevitably invisibility, lack of services. It's also a relatively small system. There's only about 700 women in the federal system on a given day, 3,000 in the provincial and territorial systems. When you compare that to the US, it makes us look very good, but actually Canada's a very small country and we have one of the most incarceration in the Western world. So a given day is one thing, but the people flowing through on a yearly basis is quite another. The other issue with our systems in Canada is that almost all, relatively speaking, so the vast majority, up to 80%, are remanded and being pre-trial, pre-conviction, pre-sentencing. So as a result, we have a very large, very expensive system of people who currently are innocent until proven guilty.
What? You mean most of the people in jail and prison haven't been sentenced?
Most.
No.
And you know, when we look at that from a gender lens, so the way bail works in Canada, it isn't so much a cash bail system like in the US we hear about on our TV shows. It's based on surety. So you need someone to assure the court that they will not get into trouble. And women are so stigmatized for our deviant behaviors that people are less likely to step up for women. Very similarly, most of the women who are in the criminal justice system are single mothers who have dependents and don't have a partner who is supporting them. Whereas most of the men in the system do have at least one partner and other parent of their children who shows up for them. Racism. So we have really concrete data about anti-Indigenous racism in the system. We don't have as concrete data about anti-Black, xenophobic, anti-newcomer, and certainly homophobic and transphobic trends in incarceration, just because we don't collect that data. So it's a kind of see no evil,
There is no evil.
Convenient.
Yeah, a very convenient situation. There are problems to collecting this data. What are the consequences of telling the justice system, carceral system, that you are queer? What are the consequences? When just a few decades ago, you would lose your job in the federal service if you were thought of to be queer. We do see, from what data that is available, extremely concerning rates. Over 50% of women in prison are Indigenous, and Indigenous women are 4% of women in this country. This is wild hyper-incarceration, far exceeding the mass incarceration of Black people in the US in terms of a ratio. Okay, so in prison and pregnant, what people are experiencing is, for starters, extreme stress. It's very dirty, and it's very overstim and understim at the same time. You're all alone, and yet you're always watched. Very, very, very stressful. And food is a huge issue. Malnutrition is rampant, which of course has very serious implications in the prenatal period. So what we have data showing is an association between any time incarceration in your life and poor outcomes for your mate. So even if you were not incarcerated during the pregnancy, if you have ever been incarcerated, it will affect the health of your baby in terms of prematurity, number one reason for death of children in Canada, infant mortality, and also small for gestational age, low birth weight, other markers for complications in early life. Okay, so let's just juxtapose this with abortion. Here in Canada, we've had completely decriminalized abortion since '88, the Morgentaler decision. This is unlike anywhere else in the entire world. We are the only jurisdiction in the globe with absolutely no restrictions in law on abortion. No waiting times, no gestational age limitations, no parental consent requirements, nothing. It is a health service, like a penicillin prescription, like hip arthroplasty, that's that. However, until 2016, which was a real turning point nationally, and we've had some local turning points before and just after that that are separate nuances to consider, but anyway, nationally, only physicians were authorized to prescribe. This isn't a criminal law situation, this is a regulatory decision. And 96% of all abortion in the country was procedural, or what used to be called surgical. This is what we think of as abortion. Going into the clinic, having your feet in the stirrups, the vacuum aspiration. This is what we conceptualize of as abortion in this country. However, since the 80s, medication has been used for abortion around the world, just not here. That's the issue with 2016. As a result of this requirement, almost all abortion was happening in very large urban centers right along the US border, causing enormous travel burdens for patients. We even had patients traveling to the US for later gestational duration care, very routinely. We also had referral requirements. So in general, you would have to first make an appointment with primary care, then get a referral to seek abortion service. So very, 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 very. Then what happened? So finally we get mifepristone, available since early 80s in Europe. 2015 it's approved, 2017 it's widely available. We worked quite hard. At the time I was the lead for LEAF Halifax, Women's Legal Education Action Fund in Halifax. LEAF was one of the national organizations that worked very hard to advocate for the public funding of mifepristone. So unlike other prescription medications, when you go to the pharmacy, the bill for Miffy is sent to the province. It's not Blue Cross, it's not out of pocket. When we first approved it, there were a bunch of problems, regulations that we had borrowed from Australia, mostly out of laziness. So Health Canada approves it, but with this suite of regulations that are very annoying. That, for instance, you have to watch the patient take the mifepristone, the first pill. that the physician has to dispense the medication, which is actually not how drugs work in Canada. Pharmacists dispense medication. That is a scope of practice error. And then most annoyingly that it could only be physicians. So one by one, our team, the Contraception and Abortion Research Team, doing work with abortion care providers and people who want to be, and communicating to Health Canada, these regulations are going to make mifepristone no more available than procedural abortion. Get rid of them. They're not evidence-based. They get rid of them all, and nurse practitioners, for the first time in Canada, are to be abortion providers. So what we have now is primary care prescribing. This is also pretty unique in the world. In theory, any prescriber in the country, any nurse practitioner, any family doctor, obviously any OBGYN, can prescribe this medication. You go to Shoppers here in Fredericton, the best pharmacy, Bowman's. He always has it in stock. You go there, you get it, it's paid for by the province, you go home, comfort of your own home, you have your abortion. It's very similar to a miscarriage. This has had a transformative impact on abortion in this country. It continues to not be talked about enough. Abortion continues to be misunderstood. 68, I'll get to it, but you know, we're seeing a huge change not only in who's doing abortion, but what patients are choosing. So the first question our team was looking at is abortion safe? Is this safe? This is a big change. Are people still okay? And yes, they are. No change in adverse events, no change in complications, no change in incompletes. Abortion is still safe. What we do see is that a procedural abortion is falling very quickly. In the first 2 years in which we have data, we see it go from 96% to 63%. The abortion rate itself doesn't change. Abortion rate in Canada, very low. One of the lowest in the world. And that's because of our extremely high economic status, good education system. What we also see is the rate of second trimester abortion decline. This makes sense. People have easier, faster access, and so they're not facing delays and they're not getting pushed into the second trimester. Wonderful, that's wonderful for them. It's also wonderful for us as clinicians because it's so much safer. The earlier you have your abortion, vastly safer. Similarly, in New Brunswick, if you guys want to jot down that website, that is an active website where all of the updated information for New Brunswick, the numbers you call for direct appointment booking, it's all right there. And I think we have it in 4 languages now. All right, so back to prison. So this is all great, this sounds really great. Canada's doing wonderful. But what about prisoners? This incredibly marginalized and oppressed population. We did a review last year looking at, okay, globally, what do we know about the intersection between abortion and incarceration? And we see a mixed bag, what people are even looking at. What people are identifying is a lack of on-site options, contraception coercion. So encountering either healthcare staff or even correctional staff in the context that are pushing them to go on contraceptives. And of course, as abortion nurses, we love contraception, but not in a coercive and frankly violent environment. You know, this is a global review, so we do see financial costs that are individual personal burdens on the prisoners, and incarceration causing disruptions in your insurance and continuity of care. Okay. So here is just a quote from one of the qualitative studies. It made me seem like they really wanted to put me on birth control here. They asked me a bunch of questions and I answered about like sex and stuff like that. Afterwards, they're like trying to get me to start on birth control. And obviously I said no, because I would rather do that not here, because I'm in here and I kind of just don't want more things that I feel like I have no control over. Really important, because I think it's very easy for us clinically to say, well, why wouldn't you want birth control? You could arrest all of your menstruation. That would be fabulous, but that's disgusting in prison and super painful. You can get some kind of a long-acting option that will make your life easy when you get out. Why wouldn't you want to do this? And it's the context itself that is so violent that it feels like the opposite of taking control over your own body. All right, so our emergent questions, having done this review for Canada, were what are the policies governing access to abortion in prisons, and what is the distance to procedural care? We'll get to the question of why we focused on procedural in a second. Okay, so distance. A while ago, we built an inventory of all of the prisons for women and girls in the country, because it didn't exist. There's 14 different systems, at least, plus all the psychiatric forensic facilities. So we put them all together and figured out how many there were and which ones were co-ed with men, which ones were attached to forensic hospitals, the different properties of these different places. And at that time, we measured the distance to maternity care. This was an earlier project of ours. So this study is looking at geomapping to these 70-ish facilities from the 92-ish procedural abortion sites in the country. And what we see is a difference from literal a block away to over 700 kilometers. So all of this information about prisons is news to us working in abortion care, right? These are people who dedicate their lives to reproductive justice, and yet prison is a black box. So as abortion care providers, we don't know what they need. The purpose of this project is to have these lived experience experts inform healthcare providers about what they need to know. We're doing a survey in the New Brunswick and Nova Scotia prisons about reproductive health indicators, because we have no data. So we're going to start in small jurisdictions where we have very strong connections and get those indicators. And what we have in proposal stage right now is a national study looking at what are those pathways to care. Does anybody get on a plane and go 700 kilometers? Has that ever happened? Yeah. So, last word, abortion in Canada, lots of things are great. We have absolutely no routine data collection about reproductive health indicators in the prison system. It's a very coercive environment with just all around threats to reproductive autonomy. People in prison have very high healthcare needs, period. So some of the people we talk to, they say like, well, this will never get to the list of things I need because I need my methadone this morning. And I have to fight every day to make sure that appointment happens. This is so far down the list of things I'm going to worry about. Procedures are a barrier to care, and there's a lack of policy affirming what we do have constitutional protection for. Here are some of those studies that I mentioned and some DOIs to connect to them. And this is how to reach me. All right, that's it. So, what are your questions? What are your thoughts? The 14 had nothing to say.